Assalamu alaikum. Today I would like to talk on nephrotic syndrome. In nephrotic syndrome, what you have to remember, there are four things, that is hypoalbuminemia, hyperlipidemia, hypoalbuminemia, hypogammaglobulinemia. Why hypoalbuminemia? If there is hypoalbuminemia, it causes pitting edema. Hypoalbuminemia causing pitting edema. As there is decreased albumin, decreased oncotic pressure, and increased fluid in the interstitial space. There is hypogammaglobulinemia. For hypogammaglobulinemia, there is infection, increased risk of infection due to hypogammaglobulinemia. There is hyperlipidemia and hypercholesterolemia. There is hyperlipidemia, hypercholesterolemia, and there is hypercoagulable state. It is due to antithrombin 3 deficiency. When there is antithrombin 3 deficiency, at that particular moment, due to loss of antithrombin 3, at that particular moment he will find that person has that person might develop hypercoagulable state. If you think about nephrotic syndrome, first of all, if it is a child, then you should go with this diagnosis. Just simply you can think that that baby might have MCT. That means a minimal change in disease. It is more common in children. It is associated with Hodgkin lymphoma. In Hodgkin lymphoma, we know that we get red Steinberg cell. Hodgkin lymphoma, it is associated with Hodgkin lymphoma. Most commonly it is idiopathic, but it may be due to Hodgkin lymphoma. Or what you have to do is to remember these three things: H and E stain. In H and E stain, you get normal glomeruli. So you have to understand what is normal glomeruli. In H and E stain, you may get normal glomeruli. There is effacement of the food process. On electron microscope. There is effacement of food process. There is effacement of food process. And third of all, there is no immune complex deposition. In immunofluorescence, there is no immune complex deposition. So in MCD, in minimal change disease, you have to remember these three things. What are those? You have to remember that these are usually children. Most common association is Hodgkin lymphoma, mostly idiopathic. Most common association is Hodgkin lymphoma, and in H and E stain, in electron microscope, and in immunofluorescence. In H and E stain, there is normal glomeruli. In electron microscope, there is effacement of the food process, and finally in immunofluorescence, there is no immune complex deposition. Then the next one, this is FSG, that means focal segmental glomerulosclerosis. In focal segmental glomerulosclerosis, what you have to remember, and that is, it is most commonly happens in Hispanics and African American. and African American. It is most commonly in Hispanic and mostly African American. It is focal again that treating H and E stain, immune electron microscope and immune fluorescence. In H and E stain there is there is focal and segmental glomerular sclerosis. There is focal and segmental glomerular sclerosis. There is focal and segmental glomerular sclerosis. Then the second thing is electron microscope. Then electron microscope there is effacement of food process. Effacement of food process. And in immunofluorescence, no immune complex deposition. No immune complex deposition. Association are three things you have to remember by this: HHS, heroin, HIV, and sickle cell disease. HIV, heroin, and sickle cell disease. These are the association. So in FSG, what you have to remember, that is, it usually happens in Hispanic and African American. On H and E stain there is effacement. On H and E stain there is focal and segmental glomerular sclerosis. There is focal and segmental glomerular sclerosis. In electron microscope there is effacement of the food process, and in immunofluorescence there is immune complex deposition. What are the associations? The associations are heroin, HIV, and sickle cell disease. These are the associations. Now what you have to do, that is, if you think about MCD and FSG, if you want to differentiate between MCD and FSG, you can differentiate via two things, and that is that in MCD, minimal change disease, usually happens in children. It usually happens in children. It usually occurs in adults. And in MCD, steroid responds well. On the other hand, there is poor response to steroid in FSG. Poor response to steroid in FSG. Okay, next, membranous nephropathy. Okay, in membranous nephropathy, what you have to remember, that is, it usually happens in Caucasian. Adults. It is associated with hepatitis. It is associated with hepatitis B, C, A. It is associated with hepatitis B, C, solid tumors. It is associated with hepatitis B, C, solid tumors. SLE or drugs like NSAID and cyclophosphamide. NSAIDs and cyclophosphamide. We know that cyclophosphamide causes hemorrhagic cystitis. Cyclophosphamide causes hemorrhagic cystitis. For hemorrhagic cystitis, do you know which drug is important? In hemorrhagic cystitis, the drug of choice is injection Mesna. The drug of cyclophosphamide. The drug of choice is hemorrhagic. The drug of choice is injection Mesna. Okay, what do you have to remember in membranous nephropathy? there are again these three things. I can add another page. Okay, in membranous nephropathy there are three things. There is H&E stain, there is electron microscope, there is immune fluorescence. In H&E stain there is thick glomerular basement membrane, thick glomerular basement membrane. On electron microscope there is immune complex. In electron microscope there is spike and dome appearance. There is spike and dome appearance due to subepithelial deposits. Spike and dome appearance. Spike and dome appearance due to subepithelial deposits. Subepithelial deposits, and there is on immunofluorescence. On immunofluorescence there is immune complex deposition. Granular immunofluorescence due to immune complex deposition. Okay, there is poor response to, it's like FSG, poor response to steroid and leads to renal failure. Poor response to steroid and leads to renal failure. Okay, next. Now, membranoproliferative glomerulonephritis. Proliferative okay, in membranoproliferative glomerulonephritis, what you have to remember, that is there are also some associations are, if it is subendothelial type, there are type 1 and type 2. If it is subendothelial type, if there is subendothelial type, it is due to HPV and HCV. Can you remember the membranous nephropathy association? Yes. In membranous nephropathy there is hepatitis B, C, solid tumor, SLA drugs. Can you remember the FSG association? Yes. These are heroin, HIV and sickle cell disease. And the membranoproliferative glomerulonephritis association, there are two types, subendothelial types and type 2 is intramembranous type. Subendothelial type and intramembranous type. Subendothelial and intramembranous. In intramembranous type, there is associated with C3 nephritic factor. C3 nephritic factor. This is the leading to overactivation of the complement, inflammation and low level of C3. You have to remember this because there are lots of questions regarding to this nephrotic syndrome, and it is one of them present in the UL, that there is decreased C3 level in membranoproliferative glomerulonephritis. It has the potential to create nephritic syndrome. It has the potential to create nephritic syndrome too. This C3 nephritic factor has a potential to create nephritic syndrome too. Okay, what you have to remember in this regard, that is on H&E stain thick glomerular basement membrane, thick glomerular basement membrane. And next one, there is on electron microscopy and in immunofluorescence. Immunofluorescence is granular immunofluorescence due to immune complex deposition, and it is tram track calcification. This is this is tram track appearance. This is tram track appearance. Do you remember the previous membranous nephropathy electron microscope features? That is spike and dome appearance, but in membranoproliferative glomerulonephritis there is tram track appearance. Spike and dome for membranous nephropathy and tram track for glomerulonephritis. Okay, now diabetes. Okay, in diabetes there is high serum glucose lead to non-enzymatic glycosylation of the vascular basement membrane, resulting in hyaline atherosclerosis, resulting in hyaline arteriolosclerosis. There is hyaline arteriolosclerosis. In here there is glomerular efferent arteriole is more affected than the afferent arteriole, leading to high glomerular filtration pressure. And in here you can, in a nephritic syndrome, in nephrotic syndrome, eventually progresses to in diabetes it eventually progresses to nephrotic syndrome. To prevent this to prevent the kidney injury, you can give ACE inhibitor. ACE inhibitor slows the progression of hyperfiltration induced damage. In diabetes what happens, there is hyperfiltration, and hyperfiltration induced damage occurs in diabetes. What you have to remember, there is non-enzymatic glycosylation, hyperfiltration, and to slowing the progression you can give ACE. Next, last but not the least, that is systemic amyloidosis. In systemic amyloidosis, what you have to remember, there is amyloid deposition in the mesangium. There is amyloid deposition in the mesangium, and it causes this thing. There is amyloid deposition in the mesangium, and it results in nephrotic syndrome. And if you see it under polarized light after staining with Congo red, you can you can see as apple green birefringence, apple green birefringence, birefringence. Okay, last but not the least, in SLA patient, if the kidney is involved, usually they suffer from nephritic syndrome. If SLE patient has nephritic syndrome, then you have to think diffuse proliferative glomerulonephritis. And if the patient suffer from nephrotic syndrome, that means protein 3+, 4+, then you have to think that it is membranous nephropathy. That's all I want to tell. Inshallah, you will get benefited, and every words are taken from the book Pathoma, the great lecturer in the whole world called Dr. Abdul Sattar. Inshallah, you will be benefited.